Thank you all for joining. It's a privilege to get to speak with everybody. And I'll share with you the best data that I can find out there to help answer some of your questions about COVID with cancer, COVID vaccination, and how we may want to address this moving forward. So in today's slide deck and presentation, we're going to go through just some of the basics of COVID-19. I know many of you are familiar with symptoms, signs, some of the basics of the virus, but I want to start us at the beginning so we can talk a little bit about what the virus looks like and how vaccine efforts have tried to accommodate that. And we'll also talk about what old vaccinations looked like and how that's different from this current structure. We'll go through the different types of vaccines that are available, the different FDA emergency use approvals that are out there, what the differences might be and why we would care about that. And then we will spend a decent amount of time at the end of the presentation going through specifically COVID during cancer treatment and when we may want to treat with a vaccine or hold. So we'll try to address all of that for you. I think easy ways to bring up questions in the moment are to drop them into the chat box if we've got that feature cooking, so that you don't lose your question. And then at the end, we can make sure we circle back to all of those and open up the floor for any verbal questions.
Great. So can I just repeat that then, Dr. Alldredge? So you're asking people if they have, during the presentation, if you have a question, go ahead and get it into the chat and I'll make sure and ask it for you. And then otherwise we'll wait to the end and open up the Q&A. Did I get that right?
Yep. Sounds great.
Thank you.
And I'm also happy, Patrice, we can touch base on this too, to make these available for you all as far as some of the resource slides, phone numbers, or websites that you may want to go get a little more information from, just so you have easy access to those resources.
Terrific. Thank you so much.
Sure thing. All right, let's see if this is going to work for us. There we go. All right, so just to review, coronaviruses have long been the cause of the common cold and are not a new thing. We have struggled with pandemic-like situations in the past from different coronaviruses, but the most recent one, the SARS-CoV-2 or COVID-19, is a new strain, and it's named 19 purely because it was first characterized at the end of 2019. So there's nothing really fancy that goes into that name. We know these common symptoms. Certainly this is not a comprehensive list. And I would encourage you, if you are in any way questioning whether this is something you may have, to go check out additional online resources like the CDC. But fevers, body aches, cough and fatigue, headaches, loss of smell or loss of taste, and trouble breathing are going to be some of your biggest, most common symptoms. It's important to understand that the virus is shed in saliva, in semen, and in feces. Now, with semen and with feces, we've not had as much time to investigate those, and it seems like that transmission is quite low. And most commonly, this is spread through saliva. So that's as droplets in our coughing, laughing, sneezing, any sort of mucosal contamination onto our hands, and then passing that on solid surfaces or through the air. We do know that the incubation period of this, from the time of an exposure until the time where symptoms start, is about 5 to 6 days, but can be hugely variable, can be anywhere from 3 days to 13 days, which is what informed some of the earlier quarantine periods of 14 days. Now, it's important to understand as well that both patients who are symptomatic and those who are asymptomatic carriers are both carrying around virus and can transmit that to others. And the amount of virus that you're carrying is about the same, whether you have symptoms or don't have symptoms. So you're just as contagious, symptoms or not. Now, the risk of death from COVID-19 is about 1%, and we can compare that to things like MERS in the past, which was like 35% risk of death, which was horrendous, compared to something like the flu, which has about a 0.1% risk of death. So while the risk of death is low, we will spend some time talking today about why we care so much about the other 99% of patients who aren't dying, but can have some long-term sequelae. Oh, sorry, my computer's giving me attitude. There we go. So just to touch base on how vaccines worked prior to this pandemic. Science has been working for a long, long time on ways to prevent disease, and this is one of the most effective mechanisms that we have. And vaccines primarily imitate a viral infection without actually causing that infection, so that we can train certain cells in your body that are your memory cells, that if ever they were to see that bug, that virus again, they can mount an immune response to fight off that new invader. So those memory cells are really important. And if we can introduce a virus without causing an illness, we can induce those memory T cells and those antibody producing cells to sit tight, just in case we need them with a future exposure.
We do have a question for
Sure.
you, Dr. Alldredge. Is it best to clean off groceries since virus can be on hands?
Great question. So I would generally recommend that before you go into the store to put on hand sanitizer, wear your mask when you're leaving the store, to replace hand sanitizer before you get into your car, before you handle anything in your purse or your wallet, to put hand sanitizer on. So just really overuse it as much as possible. And then once you're home, I often will sort of wipe down things that I feel like are in really common areas. Things where people are going to touch handles and then touch products. I tend to wipe those down, like milk or things that came out of fridges, where there's just a lot of touching in one place with multiple people. I know some folks are spraying everything down with Lysol. I would tell you, I don't know exactly what the right decision here is. Just hypervigilance with everything that you're touching once you're home. And then I often would recommend just washing hands with soap and water once you're done sort of unloading groceries as well. So hopefully that answers that with some sort of guidance, but truly there's so much variability and unknown here, I couldn't tell you the perfect way. Just to circle back, the types of vaccines that are out there in the world right now are using different parts of viral particles to create this immune reaction. So there are some, like the MMR vaccine or the varicella vaccine, that actually use portions of live virus that are lost to the machinery that can help them replicate, but are still live virus. And those are vaccines we want to avoid in any sort of patient who's getting immunosuppressive chemotherapy. And that's been a long-standing practice. All of the other types of vaccines that are listed here are safe to give during chemotherapy when you have immune suppression. Those can be things like using a virus that the whole virus is there, but it's inactive, using just the toxin the virus produces, taking pieces and parts of that virus and creating a vaccine with just the parts or subunits, or linking up some of those parts with some sugar links. So lots of different ways vaccines have been studied in the past. And that's different than what we're doing with the COVID-19 vaccine. So just to do a little science review here on what the heck is mRNA, because I know that's a term that we're talking about a lot lately. So messenger RNA, or mRNA, is the copied strand of genetic code. So it's the copy of DNA that then exits the nucleus, goes out into the cytoplasm of a cell, and directs the building blocks to make a protein. So this photo in the left is the best explanation I could find for this. So DNA is your recipe book. You're gonna take a photocopy of that, and then mRNA is your recipe. You're taking it out, that's what you're building all your proteins off of. So an mRNA vaccine has actually been studied for quite a long time. We've looked at this in influenza, Zika, rabies, CMV, and those are all still underway. But the idea of using mRNA as this blueprint or recipe is not new. It's something we've been trying for a really long time. And what we know is that typically vaccine development takes in the order of 10 to 20 years to get things completely investigated in every way, shape, or form, get those through normal FDA approval channels. So right now, there are not other mRNA vaccines that are FDA approved. There was some study of some of the other coronavirus strains I was telling you about, like SARS or MERS, when those arose in the past 2 decades. we did start to develop mRNA vaccines against those, and those just ran out of money. So just as a way of putting a plug out there, that funding of cancer research and vaccine research is super important so that we can get some of these answers. So the way that scientists very rapidly developed a vaccine for COVID-19 was by targeting mRNA as a very promising technologic approach to this. And then we basically are taking the recipe for a spike protein. So the COVID-19 vaccine is delivering the instructions to make this spike protein into your body so that your body is ready to fight against that spike protein if ever it saw it in the future. Now, I put in the right bottom corner here a picture of the spike protein. A virus basically has a shell all around it and has several projecting proteins on the surface of it that help it to find where it wants to go and direct its movements and its replication. So the spike protein is one of these. It's on the surface of all of the COVID-19 virus, and so it's an easy thing for our body to recognize as a foreign invader. So the virus, the mRNA vaccine, is not a piece of virus. It's not active virus in any way, shape, or form, and does not cause COVID. So I just want to make sure that that's really clear, that this is just a surface protein recipe. So one of the questions I had touched on a little bit ago is, with such a high survival rate of 99%, really, why should we care about a vaccine? And it's important to understand that while only 1% of patients may die from COVID-19, that there are substantial long-term side effects that can come from those who do have an infection. So those can be things like heart damage or a risk of heart failure, lung scarring that can be permanent, paralysis, stroke, seizures, potentially an increased risk of some Alzheimer's disease or Parkinson's type disorders, kidney injury, hair loss. There can be a lot of substantial downstream organ damage issues that can follow this forward for those patients who don't pass away from the disease. They did do a study in the UK looking at patients who were 8 weeks out from their COVID infection, and 72% of those patients still had notable tiredness, breathlessness, and 50% still had lingering psychologic distress. So even short-term side effects are substantial in addition to these long-term issues. So for those who have been exposed, the vaccine still has some important implications to try to prevent reinfection. And we just have the general public health interest of the more people we can get vaccinated, the faster we can get some control of this situation. A big question in the era of vaccines and those against vaccines is, what exactly is in that vaccine? So the FDA and drug companies have been very transparent about what is in that vial and what's being delivered into your arm when you have a vaccine. So outside of the mRNA, that's the meat of what we need to create this memory against COVID, there are lipids, which are just fats that help deliver that to where it needs to go, electrolytes, which are just normal blood salts that are in your system at all time, and then some sugar. That's it. All of these things are naturally occurring. They're all in your body already, except for that spike protein mRNA. There's no additives like aluminum, mercury, egg, food allergens. None of those things are in this vaccination. So it's important to understand safety because of the absence of those preservatives. Regardless of all of that, there can be some vaccine reactions that we expect to encounter. And as someone who's been through the vaccine now with the second dose, these are real. So these can be not side effects of the virus or the spike protein that your body is building antibodies against, but actually side effects because of the immune response of your body fighting against this new spike protein. So these can be things like increased soreness or pain or redness around an injection site, headache, which is definitely a shooting discomfort into the head, pretty significant fatigue or joint pain, muscle pain, lymph node swelling or discomfort or fevers. So these are the most common side effects of the vaccine. And because this has been rolled out more quickly than most vaccines have ever, come to the market, they are providing several different platforms to give feedback about vaccine reactions so that we have more robust detail to help future patients with. So online, this VAERS system is a reporting system that you can access through your laptop. And then the vSafe is an app that you can download onto any phone. And both of those are the same government-run platforms for monitoring side effects. So please, as you're getting vaccinated, share what you're experiencing so that we can get more robust data on this.
Hey, Dr. Alldredge, I'm just curious, sorry to interject here. Is there any guidance on how long the side effects may last? I mean, is it just you have to knuckle down for a day, or have we heard if they last longer?
So typically in the range of 24 to 72 hours.
Okay.
So for some folks, it's not happening in the first 24 hours, and it's really rearing its head at 24 to 72 hours in. And for some, it's pretty immediate in the 24 hours afterwards. So usually within that first 3 days, these flare up and self-resolve. And the first vaccine, so in those who have had COVID and then they're being vaccinated, it's typically the first vaccination that tends to be a little more intensive as far as side effects. For those who have not had COVID, the first one tends to be pretty smooth, but the second one hits you hardest. And that makes a lot of sense if we think about how the vaccine's working, right? We're introducing this spike protein and we're asking your body to mount a response to fight against it. So the second time your body is seeing the protein, you're gonna start mounting a response against it. And that's what all these side effects are, is just your immune response. There are two types of COVID-19 vaccinations available in the US. I did not touch here on any that are available worldwide right now. So both the Pfizer and the Moderna vaccines are approved in the US through emergency status. So they have not gone through the typical channels that most vaccines do to get full approval. They have emergency use authorizations. These are slightly different in some of their logistics as far as rollout, like having some storage challenges with the Pfizer vaccine due to how cold it needs to be kept. That just makes getting it out to communities a little more tricky. But as far as how this affects you, the Pfizer vaccine is given as 2 injections 21 days apart, whereas the Moderna is 28 days apart. There's a little bit of flex in here. So it can be a little early or a little bit late within those time periods, but Pfizer's at 3 weeks and Moderna's at 4 weeks. And typically once you're scheduled to get your first vaccine, you'll have a mandatory scheduling of your second vaccine.
Hey, I do have a couple questions. One is, can you prophylactically take some ibuprofen, or can you take something prophylactically to minimize your symptoms? I mean, your side effects.
So I can tell you from a just sort of a medical perspective, absolutely. There's certainly going to be no harm in pre-medicating with an NSAID medication like ibuprofen or Aleve, or using Tylenol, for example. You're certainly not going to hurt anything. You'll still mount just as robust of an immune response if you take those things beforehand. And it can help just from talking with other providers and patients who have been vaccinated. It seems to help. So certainly give it a shot. You're not going to do any harm. From a looking at big clinical trials perspective, I don't have data to support that.
And then there was another question on, do you by chance understand or have anything to share with what does MCG stands for?
Micrograms, sorry, just a dosage.
Yeah, why is the dosage so different? Do you know? Does it?
Yeah, so it has more to do with how so when I was telling you about what's in this vaccine and mRNA was the big player, mRNA's volume is far less than 1 microgram. So the other volumes here, the 30 micrograms or 100 micrograms, is really mostly made up of the component parts, like the lipids, the sugars, and the electrolytes that are in there. So that's really the only difference, not that one
two different recipes
stronger than the other.
the two different recipes, one has more sugar than the other.
Yeah, that's
Kind
a
of
good
thing.
way to think of it.
Okay, hold on one sec. I had a couple others.
Okay.
Can you get COVID in the period in between the two vaccines?
Yeah, so it's possible. So I'm just going to finish out this slide, and that may answer this question a little bit.
Okay.
So what we know right now, we have trials in each of these two different pharmaceutical companies. So the Moderna trial was 30,000, the Pfizer trial 36,000, which are both very good patient samples for such a fast effort. And we're at 95% effective for both. So they seem to be overall very equivalent, slightly different age groups for these two. So anyone under 16 at this time, there is no data to support safety in those folks. What we do know is that the vaccine after the first injection looks to be about 60 to 70% effective. So to your question of, can you still get COVID even after the first shot? Absolutely. You do not have full protection against experiencing symptoms until you are at least 1 to 2 weeks out from your second dose. Now, how long that effect lasts is completely unknown. I hate as a doctor having to tell you, I don't know, but the truth is we just don't know yet how long this is going to last. Is this going to be something like the flu shot where we need to do it once a year and re-up it? Will it be like an MMR that we get to redo every 5 to 10 years? I don't know. So we'll have to take that as it comes. For every day we are out from completion of the trial is 1 day's more of data we have to support that. And so it is a moving target on a daily basis, how durable the response is. But your maximum effect is not going to be until about 1 to 2 weeks out from the second dose.
There's a question on, do people have any choice about which vaccine they'll receive?
Unfortunately, at this point, it doesn't seem like we do. So the Colorado Department of Public Health is coordinating getting these vaccines distributed, and patients typically aren't getting any choice. It sort of goes with whatever site has whatever vaccine. And we'll touch on this too, because that does create some tricky scheduling issues when we're talking about giving this while on chemo, is that we don't have a choice right now of which one we get. The other thing I want to bring to your attention is that because vaccines right now are being distributed as a national public health effort, the vaccine itself is free. So if you're doing this through certain clinics, they may still have a fee that goes along with that visit to the office, but the vaccine itself is free. And it is billable to insurance companies. And if, for example, you were uninsured, there are public relief funds that are available to help offset that administration fee if you needed it.
Excuse me, Dr. Alldredge. There's a question on if there's, we talked about how kind of simple the guts of the vaccine are. Given that it didn't have preservatives, et cetera, what are triggering the major allergic reactions that some people have experienced?
So the lack of preservatives is one of the things that's made the distribution of this tricky because we're having to keep it very, very cold. So for example, the Pfizer vaccine has to be kept at -80 to -90 degrees, which are tricky refrigerators to come by. And then the Moderna vaccine less so, but still requires special refrigeration for exactly that reason, that this does not have preservatives in it. So the reactions that you're having to the vaccine are because your body is mounting an immune response to the protein recipe that the vaccine is bringing in. So it's purely an immune response and has nothing to do with a preservative response.
Where in general would people find information about side effects?
So CDC has the most, I think after perusing many websites, that the CDC really has done a nice job of guiding people through the different steps of where they may be. Are you a caretaker for someone high risk? Are you yourself someone who's high risk? If you might be having symptoms, where should you go? All of those things are really nicely laid down on their website. The University of Colorado has also tried to make a very easily accessible and easy to read COVID information center. So that's another way to get that information. One of the other big questions is, how am I going to get the vaccine? What's the plan of action for this to get to me? So that's at its core, who is getting what is dictated by the CDC, helping to guide people into risk categories. And then that's being given as guidance to states, who then have a public health department who rolls that out to the citizens of that state. So right now, I have on the right side here UC Health's plan of action for the current group being vaccinated. But I also wanted to include here just some resources for you, that if you wanted to see what exactly does this plan look like, this is the Colorado Department of Public Health's link to their website, and then all of their hotlines to call if you want to talk through some more specific or more unique circumstances that may apply to you. We've been given very, very strict guidance at the university that no matter what the circumstance is, no matter what your exposures or risks are, we can't bump people in and out of categories. So right now, a physician or a provider can't decide that you're higher risk and bump you into an earlier phase of the vaccine distribution. So for the moment, we are following the CDC's guidelines, and there's not a way for us to really get around that. That may change as we get into some further phases of the distribution plan, but for the moment, it's pretty strictly open to patients who are 70 and older, and there's not a way to get around it.
If I could just interrupt for one other quick question. So it was back to the allergic reactions. So, or just a point of clarification. So my understanding is that the allergic reactions usually happen pretty quick. And is that why they're having people have to wait 15 minutes after the shot? And do you have any sense of how often that occurs? Is it very insignificant number of people, or does it happen quite commonly?
Yeah, so very acute onset. So within that first 15 minutes, those types of reactions are exceedingly rare. And I don't have a percentage to give you. I'm so sorry. I think some of this is, for lack of a better term, it's a little bit of a CYA move. That we don't know how people are going to respond to a very quickly rolled out vaccine. And so this 15-minute let's observe you time period was built in as a safety measure for the early parts of distribution to make sure that patients were tolerating it well. As people file through those two websites I had shared with you, as they file their vaccine reactions more and more, and we have more data to better understand this, that may change. They may get rid of that 15-minute waiting period. Of the several thousand folks, faculty that I've seen get this at the university, I have not heard or met anybody who's had any sort of immediate reaction. So I think that's quite rare. So I know that this screen did not come across very nicely, and I'm so sorry about that. This is the Colorado Department of Public Health's plan of action for the phases of vaccine distribution. So this is available at that website on the last page if you'd like to actually be able to see this. My apologies. But this helps to give you a sense of the different phases that they have in place, which include healthcare providers and those over 70 in this phase 1 group. And then they're going to start to expand that out. Down here on this bottom left, you can see essential healthcare workers will be within that next group. High risk individuals in these age groups in phase 2 will roll out in the spring. And then the general population between ages 16 and 59 will roll out probably in early summer. And so this, you can't hold me to any dates on this one, or that this will roll out just as planned, but this is the state's plan of action for the moment. So now we can get to the part of the presentation that I think many of you are particularly interested in, is how does all of this apply to patients who have cancer? So the bottom line answer to that is I don't know. So we have all of these data I'm presenting for you are from expert opinions, from panels of oncologists and infectious disease experts. All of the trials that were done to investigate these vaccines were done in immunocompetent adults. That means that having cancer or having any kind of immunosuppression excluded you from participating. So I can't tell you a whole heck of a lot from those trials on how that may apply to you because that data just doesn't exist. So the CDC has compiled a list of conditions that they think place people at an increased risk of COVID-19 infection, and having cancer is one of those things. Having a history of cancer, not necessarily, but an active cancer process of any kind, of any organ system, does put you at an increased risk of infection. Now, how that translates into the timing of the vaccine is not something the CDC touches on at all. So if there's any doubt in your mind what immunosuppression means, this in the bottom left is a really nice, concise YouTube video that explains what in the world this term even means. The general theme is that you have cells in your body that fight infection. Unfortunately, chemotherapy indiscriminately is killing cells that divide quickly, and your infection fighting cells are one of those. So when you're on certain chemotherapies, not all, but certain chemotherapies, your ability to fight infection is knocked down and it will recover itself typically. But there's a time period while on chemo where you don't have a strong ability to fight an infection or to mount this immune response that we need to have a successful vaccine. So if your immune system is knocked down on chemo, then if you were to be vaccinated during that time period, we can assume that you are not going to build a strong response. If we give your body the recipe to fight back, but you don't have the cells around to create that memory, you're not going to mount an immune response. And if you were to see the real deal virus, you would not have much of an ability to fight that off using your vaccine. So it may offer some protection. I can't give you any sense of what that sum means. Is it 10% of what it would have been? Is it 50%? I have no idea. We're in a data-free zone. But if you were to have current immunosuppression when you got the vaccine, presumably your response is not going to be as strong. So then that leads us to what should we do then? So the university leadership with infectious disease input and oncology input has come out with this general approach. This needs to be addressed on an individualized basis. So if you are actively on chemotherapy that causes immune suppression, you need to discuss this with your individual physician. But a general theme is that if you are on some type of oral chemotherapy, if you're on a hormone therapy, if you're on immune therapy, or if you're a cancer survivor who's not on any kind of chemotherapy, you should be vaccinated. There doesn't need to be special timing parameters in there, just go for it after confirming with your oncologist that you're in a safe place to do so. For those who are actively on chemo, we have to be a little bit more thoughtful about that. So the reason why, the concerns that we have about that are that while it might be safe, right, this is not a live virus, it's not going to cause COVID. So while it might be safe to get vaccinated while you're on chemo, you may not have a strong response, like I said, and we're not going to be able to repeat your vaccination. So we can't just give you a third shot later or give you a whole second round of vaccinations because, again, it's a completely data-free zone and we need to distribute that to the whole population before we can circle back to giving people a second dose. So we just don't want to use up our one shot at a vaccine too soon. The other thing that we have to consider is that some people are on chemo that's timed every 3 weeks or every 4 weeks. And when they're hitting their lowest blood counts is very variable. And since we don't get a choice in which of the two vaccines you get every 3 weeks or every 4 weeks, some of that timing might be a little unpredictable and hard to manage. And we may end up giving you one of your two shots during a time you cannot mount an immune response. So while you may not have side effects from the vaccine, you're also not mounting the response we need. So it makes for a very tricky conversation. And so that's why I recommend meeting with your oncologist individually, because which chemo you're on really matters about whether you can get chemo while doing the vaccine. We may be able to check blood counts right before you're timing your vaccine to make sure that there's enough there to give you a robust response. But even that is expert opinion. We don't know what numbers exactly it needs to be to give you the most robust response. So I know there's going to be lots of questions about this one because there's lots of unknowns, but I do just want to finish going through these things that even if you're vaccinated or in this time period while you're waiting to be vaccinated, it's still incredibly important to continue with social distancing, with excellent hand hygiene, and with wearing a mask, particularly if you have immunosuppression or low blood counts because of your chemo, to just try to stay away from public spaces if at all possible. The CDC's recommendations are down here in the bottom left corner if you want them. So for those who have cancer, the crux of what they're saying is have a chat with your healthcare provider about what exactly is the right situation for you. I know that that's not terribly helpful, but I do want you to know that this is all the CDC's offering for guidance here. And so I don't have much more knowledge than they do on that front. These resources are all here for you, easily clickable places to get great, reliable information. And we will open it up for questions.
Okay, that is so, number one, that's just really great presentation. Thank you so much for all the information. I'm going to catch us up on the questions that have been submitted to the chat. So we'll start with those and then we'll open it up if that's okay with you. Not necessarily in the order they were received. So everybody just give me some patience as I'm scrolling through. So I guess I'm just going to repeat a couple things that I heard you say that I think got reiterated in the chat. So you are saying people at high risk right now, there is not physicians don't have any ability to bump you into a higher category.
Correct.
So
they have on an almost daily basis send us a message that reminds us as doctors, we do not have a say in this right now.
Right. These are just rigid categories and everybody's going through as it's set down.
Well, that's frustrating because I think there are so many individualized circumstances out there that I would love to be able to say, gosh, you sure sound high risk. Let's get you this vaccine. But the truth is there is no provider discretion here. They are following these rigid categories without flexibility right now.
Somebody, Lisa asked, I was told at Rocky Mountain Cancer Centers today that there might be a one-shot vaccine instead of two coming. Any info on that?
Yeah, so that is a public health conundrum right there. So all of the vaccine studies that were done in the 65,000 patients who were enrolled in the Moderna and Pfizer vaccine trials received 2 shots. So like I mentioned, we may have 50 to 60% effectiveness with just 1 shot. That's a guesstimate. And so there has been some question from a public health perspective of should we just get everyone 1 shot, even if that means it's not as effective, just to try to protect more people. And that is a tricky one to answer. So my gestalt is that deviating from the clinical trial, we get into a no man's land of data. We are completely making it up as we go if we move to just 1 shot. So I think that is a dicey move. I would hesitate to go down that road, even though I understand completely from a public health perspective where they're coming from with that thought process. You would be doing so with absolutely no science behind you. Okay. Wild West, you're just making it up. So it feels a little dangerous in my eyes.
Hey, Dr. Alldredge, depending on what category is that is being served, is that determined by the state, or is it by institutions about how much access they have to vaccine? And if so, can you confirm what category we're in right now, 1A or 1B or?
Yeah, so categories are actually, who falls into which different category is actually being decided by the CDC. So they're giving recommendations that say, we think you should dispense the vaccine based on these principles. And then states are almost uniformly choosing to follow CDC's guidelines. So it is state dependent, but Colorado is following the CDC guidelines on who falls into what tier or what phase. And so, gosh, I'm so sorry again that this one got cut off here a little bit, but who falls in here is listed over here. If you wanted a more comprehensive list of which medical conditions may put you into which phase, or which job may put you into which phase of this, though they do have more comprehensive lists on the public health website. So certainly worth checking out if you'd like more information, but these are the general categories that Colorado is rolling out based on CDC guidelines.
Great. We've got a question just on COVID. How long does the active infection last? I'm planning to see a friend on January 22nd who was confirmed COVID on December 25th. So almost a month before she was planning to see her. She had a mild case, like a bad cold. Is it safe to see her on January 22nd?
So that can be really tricky. So some people seem to be holding on to active virus and being able to shed that virus more than others. So having a longer period where they can be contagious. In general, the incubation period, the time where you're carrying around active virus, is less than 14 days, whether you're symptomatic or not symptomatic, as a general rule. But I would tell you it's kind of all over the place. So at a month out, I would say you are probably in a safe place. I could not tell you that 100% though.
Carrie asks, or says, it is my understanding that you can still be a carrier of COVID even after receiving both vaccines. Is that correct?
Yeah, that's a great question. So right now it seems like the answer to that is yes, that the vaccine's job is to make it so that if your body were exposed to the COVID-19 virus, that you have all the tools that you need to fight against that and clear it before it has time to cause any sort of effects within your body. That does not mean that you can't still carry virus around or transmit it to others. So that's where it's very important that even after the vaccine's on board, until all people have been vaccinated, that we still need to be wearing masks, doing hand hygiene and social distancing, because from the data that is apparent now, yes, it looks like you are still able to pass it on.
Great. So that, again, I'm just going to reiterate also per Carrie's question. So that means somebody's been vaccinated doesn't mean that you can go make out with them. They might.
Shorter than being your spouse, and in which case I'd say that ship has sailed. I would not.
Yeah. Okay. When we were talking about, and I think you did have this listed on your presentation, about that you thought that, well, number one, it sounded like anybody in treatment needs to speak with their physician about when they are getting the vaccination. But one of the things I remember from your thing is it said if you're on oral chemo, you should go ahead and get the vaccination. And so someone's asking, does that include, does that mean PARP inhibitors? If you're on a PARP inhibitor now as maintenance, do you go ahead? Or do you?
Question. Yeah, so for oral chemo, which for our folks here is typically going to be a PARP inhibitor, then in the first month when you're on that therapy, there can be some level of immune suppression that happens, and it's rare but can happen. So I would say if you are just starting your PARP inhibitor, you may want to have that chat with your oncologist about safety. Outside of that, if you've been on a PARP inhibitor for some time, then no, I don't think there's any sort of safety issue there.
Okay, so and I hate to be like splitting hairs. Does some time mean like 2 to 3 months, or?
I would say outside of that first month.
Okay.
So if you typically with a PARP inhibitor, once someone's started, you're going to do weekly blood counts for that first month and get watched pretty closely, and often visit with your oncologist at the end of that first month just to make sure we're in a good place with that therapy. And then we sort of let you go for a few months and assume that things are just as safe as they were at that 1 month period. And so if you're in that first month, have a chat with your oncologist. Outside of the first month of a PARP inhibitor, you should be in a safe place and are safe to get the vaccine.
Great. I think that answers a couple questions in the chats. Diane has asked, do you need to stop supplements during the vaccination process?
There's not any data to support that that's necessary. So, I mean, again, we're in some of this is data-free zone, but I think that that would be safe to continue what you're taking.
There, also Diane asks, since the new strains are more contagious, is that just still through droplets, or is there anything else that we should do to kind of up our protections against these new strains?
Yeah, so really interestingly, the initial strain of COVID-19 that was sweeping the world early in February and March is actually not the most predominant strain anymore. Viruses very quickly make adaptations and have small mutations. And so having new strains of viruses is super common. And so the most predominant version of COVID that's out there right now is actually the second strain of it that came around. And so most recently, starting in the UK and making its way here, has been this third strain, which is potentially more contagious, although not more deadly. And the vaccine, because it's working against that surface spike protein, should still be effective against all of these strains because the spike protein is not mutating. That's no different. So your ability to mount an immune response against the spike protein, against the surface of the virus, is the same regardless of which strain you're exposed to.
Great. So all we do is make sure to keep on keeping on.
I guess that's the root of the presentation. I think that the biggest takeaways are that I understand that this is a scary thing because it's a lot of unknown information. For most folks, those who are in remission, who are on oral chemos, hormones, immune therapies, this is safe. Go for it. For those who are on a chemo that knocks down your bone marrow, we just need to have a chat about how exactly to time that, how to try to balance getting you an effective vaccine versus trying to get it on board as quick as possible. So those, I hate to not be able to give a blanket statement about when and how we should be getting this to you, but for the most part, this is safe for you to get as soon as you fall into the category for distribution outside of those folks who are actively on chemo. We need to have a chat if that's the case.
Do people that have drug allergies, are they more at risk for a reaction or anaphylaxis to this? Ask Carol.
Not typically. So there are some vaccines, like the flu vaccine, for example, that has some food allergen restrictions with it. There are some vaccines that have preservatives in them that can have some allergic type reaction. Because this vaccine really is pretty pure, it's just the supportive blood salts, sugars that we need, and the mRNA. There aren't allergies that should preclude this unless you've had severe like anaphylactic reactions where you have to have a tube in your throat, you can't breathe. When you get a vaccine, there are not restrictions on this.
And then there was a question here. Can you just remind us again of the, well, Diane asks, can you recap reactions that are more intense after the first and second injection?
Yeah, so it depends a little bit on if you've had COVID before. So if you've had COVID before, the first vaccine shot tends to cause more symptoms. If you have not had COVID before, the first shot's usually pretty darn smooth, and it's the second shot that really knocks people down. The most common vaccine reactions are going to be muscle soreness or muscle pain, joint pain, fevers, and headaches. Certainly, I have heard of a lot of folks having the lymph node swelling or discomfort, particularly in the neck area. And then the actual injection site at your arm is quite a bit more tender than most vaccines. On both the first and second injection. The local reaction at your muscle there is not pleasant. Just as another question that may not have been asked, this is not something that we can give through your port. It's not an IV option, it has to be intramuscular. So unfortunately, we can't give it that way.
Jean asks, what is a non-robust reaction to the first vaccine, and would that determine if someone does not get a second shot?
So right now, there's not any way for us to quantify how good someone's response is. So there's not a blood test or any sort of marker that says your response has been good or mediocre or poor. So when you sign up for your first vaccine, you will automatically get your appointment for your second vaccine, and there's no assessment of whether you should be getting the second shot. You just get it. That does lead us to that tricky spot of, if you get the first shot while you're immunosuppressed, how good is your response? The trouble is, we don't have a way of measuring that. There's no reliable blood test, titer level, antibody level, anything like that that we can use to guide decisions about that right now.
It looks like Trish is offering to share a homeopathic solution for some of the side effects. Trish, you want to go ahead and unmute and share?
Hi, my doctor is here in Fort Collins, and she's given this to me and my kids for flu shots and things of that sort. And it's I don't know if you can see it, but it's basically, it doesn't mean that you're not going to get symptoms. It just says it's BAC detox. I'll write it in the chat. But I've had the kids, so before flu shots, I'll take it like just a couple drops a couple days before and a couple days after. And it's supposed to help with, like it specifically says, fever, pain, redness, weakness, lack of energy, and swelling. So it could be, something that might help with the symptoms, not get them away, but, I just wanted to offer that.
Thanks so much.
I'll put it in the chat.
Now, I know that, I did my best, but I'm not so good always at juggling, doing more than one thing at once. So I may have missed your question. So feel free to, if you have a question that you don't feel got answered, now would be the time to ask Dr. Alldredge, who's been so kind with her time. I guess I'm just going to say, in the meantime, because I'm the Ms. Summarizer, is that it sounds like, in general, unless you're right in the middle of treatment, it sounds like that we should all be getting vaccinated, that the allergic responses have been fairly insignificant, although for those people that have them, not insignificant. And that talking to your physician, if you have any questions, is absolutely recommended and supported. But that the big problem is that if you're in treatment, is that your body won't make the most of the vaccine and you won't have access to getting another round. So it's basically making the vaccine work for you. So you don't want to get it when it won't work for you, because you're screwed out of getting another chance the way things are right now.
And I would let you know that your individual oncologists may have their own personal opinions on this, and that's totally fair. The reality is that all of these recommendations of what we should be doing with the vaccine in cancer patients, in patients who have immunosuppression, are all based on expert opinion. And if you get 100 people in a room, there's no way 100 of them are going to agree on the right course of action here. So certainly what I'm saying now is pulled from the American Society of Clinical Oncology and the American Society of Hematology and Oncology and their consensus recommendations. And so there is a lot of room out there for interpretation, because this is such a sparse area for good, solid scientific data. So we're all trying to kind of make the best of a tricky situation where we don't have much data to go on. So thank you for your understanding that we, as physicians, may not have the perfect answer or solution, and that we're all just going off of the best available data that's out there.
Here's a question from Lisa. For those of us who take mistletoe, is there any feelings, recommendations on whether to keep taking or stop taking it for some time beforehand, before receiving the vaccination?
You know, I would have to look into that a little bit more specifically as far as impacts of mistletoe on your immune function. I'm happy to look into that and try to get you a better answer. Off the top of my head, I'm not super confident on that one.
Dr. Alldredge, I'd really appreciate that for our women, because there are, you know, quite a few people that pursue some alternative supplemental things for their treatment. So that would be neat to know.
I'm happy to see if that has been investigated in any way, shape, or form in the context of COVID or the vaccine. If it hasn't, we may have to see if there's any data on prior vaccines. I'll see what I can find for you.
Thank you. That's very kind. I'm just looking real quick into the chat again. Jean asks, I received Doxil Q4 weeks and Avastin Q2 weeks. Would it perhaps be better to get the shot prior to one of the Avastin infusions as opposed to Doxil? But I mean, she shouldn't be getting it, sounds like, from this conversation if you're in the middle of treatment.
So it's tricky. I wouldn't say that if you're on treatment, it's an absolute no. What we need to do though is aim for a time when your immune system is at its absolute strongest, which is typically right before you get chemo. So most of the chemotherapies that we're using knock down that infection fighting cell count around that 7 to 14 day mark. So right around the middle of your cycle is when those counts are at their lowest, and is the time we should absolutely avoid giving this vaccine, right? Because that's your lowest shot at mounting an immune response. So if we were going to time it to give it while you're on chemo, we would actually want to give it right before you do your Doxil or your carboplatin or whatever immunosuppressive chemo you're on. The tricky thing that comes here though is that if you're going to get the Moderna vaccine that's at 28 days, beautiful. You could get that right before 2 cycles of Doxil, and it would be timed perfectly. But if you get the Pfizer vaccine and the second shot is 3 weeks in, you may still have some immune suppression there. And so that's where some of this trickiness comes from, is that because we don't have a say in which vaccine you get at this point, the timing of this is harder. And so individually, you may just want to chat with your oncologist about where in my cycle should I aim for if I do want to get vaccinated, or should I just wait till I'm done with treatment?
Wow, this is a bigger, bigger question than all of these. Bigger questions than I realized. So thank you so much for your time.